In this video, we're going to cover anaphylaxis and its assessment and treatment, as well as a few other things. I know some of this information can be a little bit dry, but I think it's super important for you guys to know, especially as UEMR providers. I'm going to go into a little bit extra detail on some topics, particularly the etiology and pathophysiology, but I think it's kind of interesting to know those things as well. Let's jump right into it. Here's a little bit of an overview. So, as I'm sure all of you know, anaphylaxis is a life-threatening allergic reaction, and almost 41 million Americans suffer from this. That's almost 13% of the United States population. It's a sizable amount. So I was reading an interesting study regarding allergies and university students. The study talked about how food allergies may affect up to 8% of teenagers and young adults. Teenagers and young adults especially seem to be at a higher risk for fatal allergic reactions, maybe because of the risk-taking behavior they exhibit and reluctance to use epinephrine. Also, college may be the first time that these people are away from parental supervision, and so now they're fully responsible for self-management of their allergy. Risks of allergic reactions may be increased because of things like social pressures against proper allergen avoidance and prompt treatment, as well as factors associated with obtaining meals that are prepared by others. So the whole point of that, I'm just trying to say, be prepared for a call where someone suffers from anaphylactic shock. It's almost definitely going to happen. People can be allergic to almost anything, but the most common triggers include food items such as nuts, fish, milk, and eggs, latex, medication. Actually, a lot of people who have drug allergies are usually allergic to penicillin. And insect stings from bees, wasps, or ants. Come to think of it, I've actually never seen a bee or a wasp at UTD, so this may not be as common. I don't know, though. Alright, so I'm sure all of you guys have learned this already if you've taken Bio 2 or A&P, but I'm going to reiterate all this material just to make sure we're all on the same page. So anaphylaxis occurs because the immune system responds to an allergen. And as I'm sure you guys know, the immune system isn't a true body system, right? It's made up of the lymphatic system, bone marrow, the spleen, and the white blood cells that circulate in your body. It's responsible for detecting and clearing potentially infectious agents. It does this with the help of antibodies. One antibody in particular, IgE, is most commonly associated with allergic disease, and it's thought to mediate an exaggerated or maladaptive immune response to antigens. Once an antigen-specific IgE antibody has been produced, re-exposure of the host to that particular antigen usually results in the typical immediate hypersensitivity reaction. This reaction occurs within minutes of exposure to the offending agent, and this is why you see those immediate effects such as hypotension, bronchospasm, urticaria, pruritus, vomiting, diarrhea, etc. So when IgE is released, it circulates through the blood and lymph. Other specialized cells of the immune system, such as mast cells and basophils, are located in specific parts of the body, such as the respiratory and GI tract. When IgE contacts these cells, they release a variety of chemicals, including histamine. Normally, histamine stimulates two receptors found in the body, H1 receptors that cause bronchoconstriction and increases movement through the GI tract, and H2 receptors, which cause peripheral vasodilation and the release of gastric acid. Combined, these reactions are trying to reduce the chances of more antigens from entering the body and remove them from the body more quickly. Histamine also causes the body to release its water into the interstitial space to help bring more white blood cells to the site of infection. But this process goes into overdrive during an allergic reaction. People with allergies appear to release a much larger amount of histamine than normal. The H1 and H2 receptor sites are overstimulated, causing the symptoms you typically see with allergies like runny or stuffy nose, sneezing, wheezing, and watery, itchy eyes. If the reaction worsens, then multiple body systems are affected, including the cardiovascular, respiratory, gastrointestinal, and integumentary. Patients can also develop urticaria, also known as hives, that can be really itchy as fluid shifts into the sublayers of the skin. And there's also the release of a chemical known as SRS-A which stands for slow reacting substance of anaphylaxis, that greatly increases histamine's effects, and this is what causes the bronchial spasms, and because of that, you have wheezing and difficulty breathing as well. In a severe allergic reaction, the body is overwhelmed by its own immune response, which leads to things like hypotension, hypoxia, or altered mental status. During anaphylaxis, a lot of fluid shifts from the vasculature into the interstitial space. This loss of volume, combined with a significant vasodilation that causes BP to drop quickly. The patient's heart rate is typically increased to basically compensate for the drop in blood pressure and increasing hypoxia. Also, angioedema can occur in the patient's facial, neck, upper, and lower airway tissues, compromising the airway. Because of that, it becomes harder to breathe. The GI system is overstimulated as well, and that can cause nausea and even vomiting to occur. Okay, so how do you identify anaphylaxis in the field? This diagram here is read left to right, and it shows when a patient could be possibly suffering from anaphylaxis. So if there's known exposure, let's say you were responding to a call in the dining hall, and the patient tells you he accidentally ate a dessert that was made with nuts. You take his BP and it's pretty low. So you have known exposure and you have hypotension. He's probably having an anaphylactic episode, and you should intervene without wasting any time. If you and the patient aren't completely sure if he was exposed to a known trigger, but at least two of his body systems are infected, so let's say he had both abdominal cramping and angioedema, you would suspect that as anaphylaxis. And lastly, if there isn't any known exposure to an allergen, but there was an acute onset of signs like hives, flushing, angioedema, along with difficulty breathing or low blood pressure, treat it as if it's anaphylaxis. The next couple of slides are straight from our emergency medical guidelines. Once you've identified anaphylaxis, treat it promptly. If the patient has an autoinjector and hasn't used it yet, go ahead and assist them in administering it. That way you don't have to waste time getting epi out of the bag and drawing it up in a syringe. Otherwise, administer epi via the hypodermic needle and syringe into the upper arm. Of course, also consider oxygen therapy because anaphylactic patients can have a hard time breathing. You might also have to consider using a BVM if the patient's respiratory system is severely compromised. And if there's wheezing, of course, give them albuterol. Treatment is pretty much the same for a pediatric patient, except for the amount of epi you give. It's a little bit less. Here's a pediatric dosage chart, which can be found in our guidelines. I'd like to point out one thing. On campus, we get a good amount of 9 to 12-year-olds just because of all the computer science camps, engineering camps, robotic competitions, and so on that are held on campus, especially in the summer. So you might be thinking it's probably not as important to memorize the values for infants and toddlers, but I would say probably go ahead and know the values for 9 to 12-year-olds. All right, let's talk briefly about adrenaline. This isn't super important for knowing how to treat anaphylactic patients, but I think it's interesting to know how epi works. Following IM administration, the initial response to epinephrine is pretty rapid. The duration is short. It can last anywhere from 10 to 20 minutes, and injected epi is rapidly inactivated and degraded by liver enzymes, and most of it is excreted by the kidneys. The mechanism of action of epinephrine is as a sympathomimetic catecholamine that acts on both alpha and beta adrenergic receptors, which are receptors of the autonomic nervous system, specifically the sympathetic division, right? Of all the monoamine neurotransmitters, it's the most potent activator of alpha receptors, which this is what results in the intense vasoconstriction. Its beta receptor action, on the other hand, this is what promotes bronchial smooth muscle relaxation and leads to significant bronchodilation, allowing the patient to breathe better. I have some important side notes to be thinking about, particularly for children. But I want to highlight just one. You can pause the video and read the rest if you want to, but children can compensate for shock really, really well. They can initially appear to be just fine at first, but then they can crash hard and fast. So be a little bit more vigilant when you're dealing with a child. Also, be prepared for the worst. Anaphylaxis, in its worst case scenario, can lead to cardiac arrest. As EMS providers, we're constantly thinking, what's the worst that can happen, right? So be prepared to perform CPR and have an AED handy. Hopefully you won't need it. Some other notes. Antihistamines haven't been proven to stop a severe allergic reaction, so don't use that first. Go straight to epi. Also, in the previous protocols we had, the Biotel guidelines, under the allergic reaction section, they had in big, bolded, red, underlined letters that said something like making a patient sit upright after they were lying down while suffering from anaphylaxis is associated with sudden death, which I never knew, so it freaked me out. I did a little bit of research on that and found out that the statement is based on very minimal studies and it's only a hypothesis at best. So you don't really have to worry about this. They're probably not going to die if you make them sit upright. Then there's also the secondary reaction to watch out for, also known as the biphasic reaction. It can happen within 3 days of the first one. So always ask the patient if they suffered a similar episode recently, particularly within the past 3 days, and ask them if they had to administer an EpiPen. Lastly, I know in EMT school, some of us were taught that epi is a contraindication for pregnancy. Although there aren't very many studies about this, epi should still be used if the benefits outweigh the risks in that circumstance. Okay, so that concludes this presentation. These 3 points are what I want you to take away from this video. I hope you learned something new, or at least found some of this information interesting.